Welcome everyone, and thank you for joining us for the fifth session of the Leveraging Midwifery-Led Care to Address Disparities and Equity in Medicaid virtual learning series. I am Jennifer Moore, the founding executive director at the Institute for Medicaid Innovation. Before we begin today's session, we would like to thank our funder, the Yellow Chair Foundation, for their commitment to advancing important maternal health topics, especially in the Medicaid program. Through their generous and ongoing support, we are able to offer this free virtual learning series. Thank you for completing the evaluation from the last session and providing your input on potential topics to highlight during our final two sessions. We are excited to share that the two top topics that were selected included payment reform for midwifery-led care, including value-based purchasing and alternative payment models. And second, a roadmap for success, highlighting action steps for stakeholders who are seeking to advance midwifery-led care in the Medicaid population. More information about these sessions will be shared soon. Shifting back to today's session, our presenters will provide information relevant to three main learning objectives that build upon the required activities that you completed before this session. They include identify how state Medicaid agencies have leveraged their state's Medicaid contract procurement process and/or statewide maternal health efforts to improve health outcomes and equity and increase access to the midwifery-led models of care. Second, identify how states and other Medicaid stakeholders can respond to emergent needs, such as the pandemic, to increase access and coverage to midwifery-led models of care, how it has impacted care and outcomes, and what steps might be taken to explore extending changes after the emergency. And third, learn how statewide coalitions have leveraged philanthropic funding to support the development of evidence and political momentum to influence maternal health policies. Before we get started though, with our panel discussion, I'd like to hand it over to my colleague, Chloe Bext, who will review a few housekeeping items.
Good afternoon, everyone, and welcome to session number 5. I'm going to review some details for today's session along with a few reminders. First, today's session will be recorded and archived on the IMI and CHCF websites. Except for panelists, the lines will be placed automatically on mute. During the meeting, the chat feature will be disabled, but please feel free to submit your questions throughout the session in the Q&A panel, and the questions will be consolidated and shared by the moderator during that Q&A portion of our session today. At the completion of each session, you will receive an email message with a link to complete a short 5-minute evaluation survey. As a reminder, completion of the evaluation is mandatory as part of your participation in the learning series. We actively review and incorporate your feedback into our future sessions. We look forward to hearing what your thoughts are in today's evaluation. Finally, all materials will be made available to you on our website about 2 weeks after the presentation date. Dr. Moore, I hand it back to you.
Thank you, Chloe. I am pleased to introduce our presenters today. First, we have Dr. Stephanie Teleki, who is the California Healthcare Foundation's Director of Learning and Impact. She partners with the Foundation's program teams to support organizational learning, evaluate the Foundation's investments, and optimize impact. She also leads the Foundation's portfolio in maternity care as part of CHCF's focus on high-value care. This portfolio currently includes work to improve maternal mental health care and work to promote birth equity for Black mothers birthing people. Ms. Nan Strauss, the Managing Director of Policy Advocacy and Grant Making for Every Mother Counts, is joining us also today, where she leads the organization's efforts to advance policies and programs that expand access to quality, respectful, and equitable care practices for all members of the community. And finally, today we have Dr. Pamela Riley, who is the Medical Director for the Department of Healthcare Finance, overseeing medical administration and quality of care in the District of Columbia, Medicaid, CHIP, and Alliance programs. Dr. Riley received her MD from the UCLA David Geffen School of Medicine and completed her internship and residency in pediatrics at Harbor-UCLA Medical Center in Torrance, California. She received an MPH from the Harvard T.H. Chan School of Public Health as a Commonwealth Fund Fellow in Minority Health Policy. We're going to kick off today's presentations with Dr. Teleki. I hand it over to you.
Thank you, Dr. Moore. And thank you, everybody, for the opportunity to share with you the story of the effort in California to lower the rates of unnecessary C-section, which are a key driver of maternal morbidity and mortality. I was asked to share this case study as food for thought as all of us who seek to improve maternity care and maternal outcomes think on how to advance midwifery. So over the next 10 minutes, I want to share with you a little about the California Healthcare Foundation and a little about why, what, and how this collective action on C-section took place. I realize this is just one case study and it focuses on a discrete clinical issue, C-section, versus trying to advance an entire model of care, which is what we're trying to do in midwifery. So I just wanted to say that I'm sharing this with you just as one vehicle for your contemplation. Hopefully it will spark some ideas and good discussion and useful questions. Next slide. And you can go on to the next slide also. So we're on the key facts and figures slide. So a little about CHCF. We are an independent nonprofit philanthropy. We focus on the healthcare system explicitly and on the Medi-Cal population and uninsured. And we have three key goal areas. So we're trying to cover quite a bit of ground. There are a lot of different projects and focus areas within our access to care and coverage, high value care, which is where our maternity care work sits, and then a more cross-cutting unit and goal laying the foundation. All in all, we give away about $30 million annually. Next slide, please. So we're on slide 4. So with limited resources, we give away about $30 million a year. And that is not very much money in a state as big as California if we're trying to have impact across all the areas we fund in. So we at CHCF approach the healthcare system work we engage in by really thinking about the change we want to see in the world, in this case, lower rates of unnecessary C-section, and we think about the levers for change that we as a philanthropy, and importantly, in tight partnership with other stakeholders in the state, what we can support. So that's the flower diagram that you're seeing on the right. Usually you need to pull multiple levers, though maybe not all, and we try to figure out which levers are the most important for the impact we're trying to achieve and invest there most deeply. And we do this sort of prioritizing, if you will, the levers in deep engagement with stakeholders who are on the ground and know the issues the best. So each of those petals, if you will, on the flower diagram are the levers. And then into these levers, we bring our capabilities as an organization, as a philanthropic organization. So we bring our money, of course, but we also do things like really support communications. We do convenings. So there's a lot of other things that we bring to the table. And again, we know that these levers may not be all that's needed, and there may be other ways to categorize things into different levers, but generally we have found that across many, many topics in the healthcare system, that these are some of the key levers that we see over and over again as being needed. Next slide, please, and then you can go on to slide 6. So really briefly, I'm going to go very quickly over these next two slides, and I'm not going to go over all the points. These next two slides are really about sort of the problem, the increase in C-sections that we have seen over many years in California and across the country. And we all know that C-sections have a very valuable place in providing good health care, but they also are major surgery, and we don't want to overuse them. And so this effort was really about trying to bring the rates of low-risk first birth C-section down to a more reasonable number. In California, the number was from 7 to 70% at individual hospitals, so a huge variation in rates. And so we were trying to bring that down to the Healthy People 2020 goal of 23.9. Then the next slide, slide 7, is just to say that we did, over the period of 5 years, or really more like 8, decrease the rates from 26% to 22.8 at a time when the rest of the country did not see a change at all. So there was something happening in California that that seem to do something good. Next slide, please. So I want to dig in a little bit to the levers that I mentioned earlier, and I have a few slides here, each focused on one of those petals in the flower diagram. This one is, we really started with a focus on transparency, monitoring data, and really measures. And I can't overemphasize enough the importance of the measurement data lever in almost everything that we have ever been involved in. So we had a significant infrastructure in California with the Maternal Data Center at Stanford. And we had measures of our end goal. We had measures of unintended consequences, which is critically important for especially making sure we're not causing harm, and also being able to speak to the skeptics with data. And then we just did a lot of engagement of key groups. We did public reporting through several venues, including a state-sponsored honor roll, Yelp, and then also a public-facing website. And we had active engagement of the media and also surveys that were bringing in the voices of women themselves. So a lot of attention, resources, time, energy went into this lever. Next slide, please. Another important lever was the delivery system work that we did. There was an initial pilot over 3 years to test out some approaches, and then that was funded by the Robert Wood Johnson Foundation, and then CHCF came in to fund a $1.2 million initiative, a large-scale quality improvement initiative working with many hospitals, 61% of the 243 hospitals in the state that deliver babies. And there were a lot of different pieces that I'm happy to answer questions about later. We had a toolkit, we had feedback loops. Again, data were critically important, a lot of trust building and education support around not just telling people what was wrong, but how to change their behavior and their practice patterns. So this was also another very important piece of the work. Next slide, please. Another key lever was payment and engagement of health plans and other purchasers. And here we brought together the key public payers, so Medi-Cal, our state exchange, and the public and retirement system, and also the Pacific Business Group on Health that represents purchasers. And we did a lot of work with them and got them to support a lot of the efforts trying to encourage hospitals to join the Quality Improvement Collaborative and other efforts. There was also a lot of direct engagement with plans. So plans have their own different incentive programs, and we tried to connect with them and say, hey, will you include a C-section measure? And many of them did. And then we did a lot of analyses around cost and savings so that we could hopefully keep up the drumbeat of the argument that this was all worth time from an effort from a financial standpoint. Next slide, please. The last important lever that we focused on and with kind of intensity was the patient community engagement lever. And there we had an educational campaign around educating women and their families about the overuse of C-section. That was really important to the providers and purchasers because they said if we're going to do something that might seem to some like a takeaway, some people might wonder why they're not getting a C-section. They wanted to be able to have materials to help explain that. We also, as I mentioned earlier, had a survey that we funded to really bring in the voices of mothers. And, you know, a key message in all of this was, of course, mothers don't want C-sections they don't really need. And that was important to have as part of the sort of a drumbeat, again, of the project and the effort. And then we did some other things like helping to educate TV writers about this issue and just steady, constant over 5 years outreach to reporters to make sure that we had stories whenever we could in the media. So I'm going to wrap with these next few slides by just kind of recapping, reflecting on the C-section work and how it may relate to the midwifery work. So I'm on slide 10 now. The situation at the outset, really reflecting back, is that we were up against a persistent clinical challenge with a history of ups and downs over decades. So there we have some parallels with midwifery. There was a lot of misinformation and misunderstanding, both on the part of clinicians about what we were, trying to do and the value of it, and also the public, so here again, some parallels with midwifery. We also had a lot of questions around incentives and costs to whom. Doctors and hospitals feel things differently, even across hospitals. Some hospitals were being paid differentially for C-section, others were not. So a lot of complexities there. And then lastly, Medi-Cal. Medi-Cal pays for half the births in the country generally, in each state as well. And yet it's not a huge expense compared to other things like people with complex needs. So engaging Medi-Cal and really getting them at the table, especially around the payment, has been and frankly continues to be tricky. Next slide, please. On the lessons from the road, these are just 6 things to be thinking about as you think about midwifery. In the C-section work, what I think really helped is that it had very clear, explicit, and understandable goal of 23.9, a weird number that was not even arrived at in any kind of empirical way, but was the number that Healthy People 2020 picked. That became sort of a rallying cry. And so that was just a really important piece of all of this. We partnered with everyone. There was no one who came to us that we said no to. We found a place for them in this effort, both public and private sector, and that really made the effort strong. We pulled a lot of levers, and I want to have, again, a special shout out to data and measures. You can't do any of the other things that I've talked about today without having really strong data and measures to rely on. We also just kept up the drumbeat, like I mentioned. We made this effort visible everywhere we possibly could, in the media, in public reporting, in government activities, in private sector, et cetera. And that was also really important. There was really nowhere to run or hide from this C-section work in California during the 5 years that this effort was in play. We also were incredibly persistent and also patient. Change takes time. There's always going to be backsliding and need to keep pushing. And of course, the work is never done. We've seen in COVID that the C-section rates have creeped back up because there are a lot of scheduled C-sections happening, and you just always have to keep an eye on the ball. I'm going to wrap with this final slide, which is just really putting it out to all of you. Now that you've heard, this example and are thinking a little bit more about the levers, I put out to all of you, what are the levers to pull to advance midwifery in this country in a really meaningful and sticky way? And how can the stakeholders collaborate? Because it's really going to take all of us. So with that, I will wrap, and I know we are going to hear about some real world work in midwifery next and levers that people have pulled.
Thank you, Dr. Teleke. And that's a perfect setup, because now we're going to transition into a presentation from 2 real world initiatives specific to midwifery, now that we've seen the flower blossom of levers to consider as we advance this topic. So with that, I'm going to hand it over to Ms. Strauss.
Thanks so much, Dr. Moore. Good afternoon, everyone. I'm so pleased to be speaking with you all today, because increasing access to midwifery-led care has the potential to be a real game changer. It achieves the 3 goals of the triple aim for healthcare improvement: improving health outcomes and equity, enhancing the experience of care and engagement in care, and it is cost effective both in the short term and the long term. It's a high value model of care. And that is something that payers and Medicaid plans specifically can get behind. And what's exciting to me is how Medicaid's interests here align with the interests of community members and families. There are so many situations where incentives are misaligned or at odds with the interests of patients. So when that alignment exists, we need to think creatively and seize those opportunities. And that is why I'm going to talk today about expanding access to midwives in the midwifery model as part of New York's COVID-19 response, because a crisis can open the door to innovation that would be difficult to achieve in normal times. Next slide. So last March, New York City abruptly became the epicenter of the COVID-19 pandemic in the US. And in a matter of weeks, the hospitals were badly overwhelmed. And in this pressure cooker context, several hospitals announced that people couldn't have their partner or family members with them during labor and birth as a precaution to reduce COVID transmission. In just a few days, outraged advocates got 600,000 signatures on a petition urging New York's Governor Andrew Cuomo to reverse the bans on birthing support. And as early as on March 29th, Governor Cuomo took swift action and issued an executive order guaranteeing that people could have one support person of choice with them through labor and birth. He also took the step of expanding the workforce by including midwives in an order temporarily allowing healthcare providers who are licensed in other states to practice in New York State during the pandemic. Next slide. These were welcome changes, but it was clear that more was urgently needed. So we at Every Mother Counts met with the governor and his staff to ask that they specifically address maternal health during COVID with broader action. Our very top line point was to remind the governor that in normal times, 1 in 4 hospital stays is related to childbirth or newborn care. So really, any health emergency that is affecting hospitals must include specific maternity care policies. And our key asks were to immediately increase access to birth centers and to mobilize more midwives to relieve pressure on the physician workforce by bringing in midwives from out of state and fast-tracking professional licensure processes, both of which the state was doing with regard to physicians, but had not done related to midwives. Next slide. It's really tough to convey the degree of anxiety and fear that people were expressing at this time. And it was not unfounded. Women laboring in hospitals were reporting really gravely traumatic hospital experiences, like one person who talked about hearing repeatedly code blues being called for COVID patients over and over and over again throughout many hours of labor and birth. At the same time, home birth midwives and birth centers were getting so many calls that they couldn't keep up. Many simply had to stop returning calls from prospective new clients because they had no more capacity at all. Next slide. So a week after our speaking with the governor's office, they called us to ask if we could participate in a COVID-19 maternity care task force. And the stated purpose of the task force from the beginning was to develop a plan for New York State to authorize and certify additional birth centers to provide a safe alternative to stressed hospitals. The governor explicitly recognized that maternity care for many healthy people and families can be safely moved out of hospitals, freeing much needed space and resources for those affected by COVID-19, while also protecting childbearing people and their families. Next slide. The task force met over 3 days to discuss solutions, and I want to take a quick moment to highlight the composition of the task force. The strong suit was that it included federally qualified health centers. It included community-based organizations. Every Mother Counts was there as an organization representing pregnant and childbearing people. The New York Association of Birth Centers was present, as was the New York Midwives, which is the Midwifery Association. But crucially absent were midwives and administrators who were working in birth centers. And for the most part, the people there were not working with midwives at all as part of their professional work. So the composition was really dominated by hospital associations, clinicians, and organizations that don't work with midwives or have midwives on their staffs or in leadership positions. So a great deal of time had to be spent educating the participants about why and how to achieve the stated objective of certifying additional birth centers. It's a critical reminder to bring to the table the on-the-ground, hands-on experts, birth center leadership, like the midwives Ebony Marcel and Amy Romano, who you met in last month's session, who have so much wisdom and experience to share. Next slide. Following a great deal of discussion, the task force members submitted feedback to the governor's office, who they brought the feedback together and issued consensus recommendations and a corresponding executive order. The number one top recommendation was to diversify birthing options to support patient choice by expediting licensure for first, emergency birth centers established as expansions of existing facilities, and two, for new midwife-led birth centers under new regulations. Next slide. So what happened? The results, the recommendations were released at the end of April, and the results have been mixed. Next slide. 2 new birth centers were able to open, the Jazz Birthing Center in New York City and the Refuah Health Center in Valhalla, but both of these are temporary physician-led facilities. In last month's session, Amy Romano talked about setting up the much needed Jazz Birth Center, the only one right now in Manhattan. This expansion of the existing birth center in Brooklyn was made possible as a direct result of the streamlined process that was developed in response to the task force recommendations. Next slide. But there are still 0 midwifery-led birth centers in New York State, and there are no prospects for any to open soon. Why is that? When other similarly large states like Texas, California, Florida have 20, 30, even 60 freestanding birth centers open in those states. And that's because the new regulations that were drafted are as overly restrictive as the previous existing ones. And they still require a very burdensome certificate of need process, a process that is time intensive, cost prohibitive, not associated with improved quality of care, and is a particular barrier for diverse healthcare providers seeking to provide care. Next slide. So what's the alternative to a certificate of need process? Well, many states in the US, Minnesota is just one, use accreditation by the Commission for the Accreditation of Birth Centers as the only requirement for licensure for birth centers. And that's the proposal that advocates are recommending in New York State. The Commission for the Accreditation of Birth Centers, CABC, uses standards that are rooted in evidence-based practice. They're proven to promote safety and positive outcomes that the freestanding birth centers are known to achieve. Next slide. So of course, increasing access to out-of-hospital birth is critical, not just now during COVID, but beyond the pandemic as well. It's really needed in the long term to improve maternity care, because birth centers are associated with lower rates of intervention, better experiences of care, more respectful care, more equitable care, and healthcare cost savings. And this has been specifically documented among Medicaid enrolled individuals in the CMS Strong Start study, which found that people enrolled in Medicaid receiving prenatal care in birth centers experienced positive health outcomes and lower healthcare costs, including lower rates of low birth weight and preterm birth, lower rates of cesareans, and higher rates of vaginal births after cesarean than did others also enrolled in Medicaid. And mother and infant pairs receiving prenatal care in a birth center led to $2,000 in healthcare cost savings through birth in the following year, compared again to others enrolled in Medicaid. So I want to close with this list of recommendations for how to expand access to the midwifery model of care through midwifery birth centers. And these include, in addition to midwifery birth center licensure regulations that are based on the American Association of Birth Center and CABC national standards, Also adopting the Medicare policy of reimbursing midwives at 100% of the physician rate for providing the same services, reimbursing birth center facility fees, and paneling midwives without added requirements beyond those that are required by state law, increasing awareness of midwifery services among the public by including them in lists of provider networks, making sure that they're included in the search mechanism on websites, and ensuring that they're really easily found in participating provider listings. It's really important for payers, especially Medicaid programs, to create pathways for fairly compensating midwives for providing the high value care that they do offer by reimbursing at rates that are high enough to sustain midwives' practices based on their lower utilization of interventions. So thank you very much. I'm looking forward to continuing to discuss this during the Q&A.
Thank you, Ms. Strauss. And now we're going to shift to Dr. Pamela Riley, who will provide us the perspective of what DC has been able to accomplish in the midwifery space. So with that, Dr. Riley, I hand it to you.
Thank you, Jennifer. Hi, everyone. Thank you again for having me for this conversation. And as Jennifer mentioned, I'm going to be providing an overview of what DC has done and can do to further advance midwifery-led models of care in Medicaid and increase access to this model of care for Medicaid beneficiaries. I have to admit that when Jennifer first approached me about this and said that we were doing all this interesting stuff with midwifery, I said, we are. So Jennifer, you made me do my homework, but you also gave me more work to do because there's lots more we could do in DC Medicaid to advance this model. So thanks a lot, sort of. Anyway, so I'm going to be talking about some of the building blocks that we have used in DC's Medicaid program to enable and advance the use of midwifery-led models of care, including issues around licensure and scope of practice, issues around coverage for services, looking at how sites of care can support midwifery-led models of care, and finally thinking about what sustainable payment models we should be considering to better support these care models. So next slide, please. So just a quick overview. I'll give a brief background on DC's Medicaid program and our maternal health priorities, look at what we cover in terms of midwives and services, look a little bit at the role of the managed care organizations and the role that they could play in supporting midwifery-led models of care, looking at some of our expanding licensure requirements, and then finally offer a few recommendations that will hopefully build on my two previous colleagues' presentations as well. Next slide. A bit of background about DC. We are an interesting jurisdiction. We actually have a fantastic rate of healthcare coverage, the second lowest uninsured rate in the country, and we cover a large swath of DC's population. So we cover about 4 in 10 district residents. That includes all of the programs that the Department of Healthcare Finance administers, including Medicaid, CHIP, as well as our DC Healthcare Alliance program, which is for residents who are not eligible for Medicaid, usually due to immigration status. Next slide, please. And within that, it's fair to say we cover a pretty sizable share of the births in DC every year. This is just a brief snapshot of some of the characteristics of births financed by the Department of Healthcare Finance. We finance over 46% of nearly 46% of all DC births. Within that, I would say about 65% are to Black or African American women. So we're certainly have a huge responsibility in terms of having an impact on access and disparities for this population. 85% of those births were to women enrolled in managed care organizations. And we recently had another increased shift of a larger share of our population into managed care. So I imagine that MCOs will only be playing more and more of a significant role. In spite of this large share of coverage that we have, we don't see the health outcomes that we want to see. Only 71% of women had a prenatal care visit in the first trimester in 2019, and only 68% of women had a postpartum visit. So it's, in spite of the levels of coverage and access to care, or fairly widely distributed access to prenatal and postpartum care, we are not seeing the access that we want to see and the utilization and outcomes that we want to see. So this is useful in thinking about how can midwifery-led models of care play a role in ensuring more equitable access and improving maternal and infant health outcomes, particularly for Black mothers and babies in the district. Next slide, please. I do want to stress, as the other speakers have mentioned, that I cannot understate the importance of this being a priority for the district as a whole in terms of being able to advance this work. The mayor of DC has stated this as a priority, has established a perinatal maternal infant health summit that she holds annually to bring together multiple district stakeholders to really identify means of advancing maternal infant health and improving outcomes in the city. So it's a district priority, it's a health department priority, it's city council priority, and it always helps when everything's a priority. So that certainly helps to move the priority forward. And based on this being a priority for the district, as well as the issues that we've identified in our data that are lacking, we really try to align with what is Medicaid's role, is the question I always ask in the midst of all these efforts. How can Medicaid advance improving maternal health outcomes? And really our role is focusing on making sure that providers and beneficiaries have access to timely, high quality care, and in supporting the healthcare providers in being able to provide that appropriate care, and also collaborating quite closely with other government and community and provider stakeholders in really making that happen is really essential. Next slide, please. So just a high level overview of coverage of midwife services in Medicaid. I think it's a little bit stating the obvious, but we cover nurse midwives, right? And so I know a lot of states and jurisdictions do, but they're enrolled independently as Medicaid providers, step one. There's also payment parity with physicians. We pay nurse midwives at 100% of the physician rate for the same services, which our previous speaker mentioned is an important building block. We also include birth centers as enrolled providers in our Medicaid program, which again is not unique, but I think and you've heard about Community of Hope, which is our single birth center in the district, but it is an NFUHC, and the payment model and the delivery model enables midwifery-led services to exist, and it enables Medicaid beneficiaries to have access to that, which is really critical and not always the case in other states. So the FQHC approach, I think, enables it to not only be accessible to Medicaid beneficiaries, but also to be administered in a potentially more financially sustainable way. Of course, there are pluses and minuses to that, but I think it is one potential path forward. Next slide, please. I will now go into a little bit of the managed care requirements. You have a lot of information here that you can read through, but I think in terms of managed care being such an important player in terms of enabling care and midwifery-led models of care, probably the most important thing is the contract requirement to provide access to and pay for the nurse midwife services. And as we expand that, I imagine we would include the certified professional midwives in that model as well. So there's, in addition, and nurse midwives can provide the same host of services as physicians can. Next slide, please. In addition to requiring those services in MCO contracts, which is probably the biggest lever that we have, the MCOs also have the opportunity to include value add services that go above and beyond, that are not required by their contract, but they can offer above and beyond to their members. And one of those services that the MCOs have chosen to offer is sort of high-risk pregnancy management, some doula services, and as well as some services that include midwifery care. I would like to highlight Mama Toto Village as a fabulous approach. They truly support their main mode of operation is community birth workers, is what they call it. Basically, community health workers or perinatal health navigators that help women navigate and access perinatal health services. And the director is a certified professional midwife, but most of the staff are not licensed provider types. So it's great that this is offered as a value add benefit. It would be awesome if there was a way to incorporate this more formally into care delivery and payment models. The challenge does become if eligibility to enroll as a Medicaid provider versus just providing an invoiced service, if you will, to managed care beneficiaries. So I think we need to think more about how do we provide accountability and sustainable payment and models of payment that work for these models of care that include or are led by midwives and that may also include other non-licensed provider types. Next slide, please. I'll just touch on the DC Certified Professional Midwife Act. So this is good news for us. We're joining a host of other states that are will be able to license certified professional midwives. The bill also allows for certification of maternity centers, as well as Medicaid reimbursement for certified professional midwives. So this bill was effective in June 2020, but the implementation has been delayed for other reasons. Unlike New York City, who or New York, which is taking this on because of the pandemic, I think we have put it off. But we're actually, the great part is we're resuming now in terms of just having close discussions with the health department, the licensing agency, as well as the Medicaid agency in terms of what the parameters will be for provider enrollment, reimbursement, licensure, certification, maternity centers. And Nan's presentation was extremely helpful in terms of raising considerations that we should consider. So thank you. I think this is a great opportunity, but in terms of realizing that opportunity, one of the challenges that we have is how do you really support provider types who are not necessarily used to providing care in a medical setting with provider enrollment, with reimbursement, with that practice infrastructure, HIT, billing, practice management. And that's not something that's reimbursable from the Medicaid side. So this is one instance where with other priorities, we have relied heavily on potential grant opportunity support, whether federal, state, local, private foundations, TA providers, hint, hint, who want to provide that sort of support to practices in terms of really being able to take on that practice infrastructure and implement these models in a sustainable way, particularly, and kind of lower those barriers to entry and to being able to operate sustainably. So next slide, please. So I will just wrap up to say that I think we've touched on a lot of these issues, but obviously I think the floor is sort of that Medicaid coverage and payment for midwife services, payment at parity with Medicaid, or actually a step before that, licensure, which is more of the health department's role, but how do you collaborate with making that the least burdensome point of entry possible, licensure, coverage and payment for services, enabling that to be provided by MCOs in terms of contract requirements, but how do we think more creatively down the road about alternative payment approaches that are inclusive and flexible and that actually support the provider types and services and care that needs to be delivered in a holistic way. So I will stop there and happy to take any questions. Thank you.
Thank you, Dr. Riley, for your presentation, and to all of our speakers. As a reminder, please enter any questions that you have for our panelists in the Q&A box. And I'm going to ask my colleague, Karen, who's been monitoring the Q&A box during the session and has been consolidating all of your questions for the panelists. to bring forth our first question for our speakers.
Thank you so much. And we have some very interesting questions. And the first one is for Ms. Strauss. In California's Medicaid program, physician oversight requirements for certified nurse midwife-led birth centers is a huge contracting barrier. I think legislation in the state is evolving. Any advice on this for the state of New York? This is the issue of vicarious liability.
This is something that actually we have supported in California, the removal of that regulation, just as we supported it in New York, which has now been removed. And there's the question of oversight for practice and oversight for birth centers. Midwives are educated to serve as primary maternity care providers. They are qualified to do that. They work very well in collaboration with other types of care providers, and they know when to refer. So it's actually not really clinically necessary or appropriate for midwives to be stuck under supervision because they are certified to work as an independent provider. And as the as the person asking the question indicates, it creates both a financial burden and also creates in practice a lot of restrictions that come up because the physicians or the entities employing the physicians are concerned about vicarious liability. So it's a real barrier. It should be removed. It doesn't increase safety or health and is simply a barrier. So that's one of the reasons that we love the fact that we can advocate on various different levels around this issue, both policy advocacy to get the system aligned with best practices in care provision.
Mm-hmm. Thank you so much, Ms. Strauss. Appreciate that very thorough response. The next question is for Dr. Riley. Dr. Riley, could you share with us some of your thoughts and ideas about how DC has been able to leverage their request for proposal process to hold managed care organizations accountable for the language that you've placed in those RFPs? And then also, what are you doing in terms of value-based purchasing to inspire managed care organizations to meet those requirements?
At this point, I think that the probably the bare minimum is just including the requirement that the MCOs cover and provide for nurse midwife services, and we would do so for the certified professional midwife services as well. There are value-based payment placeholders, if you will, in the contract that we are very much interested in leveraging to specify more parameters around what we would expect to see. I am hoping that we can use that as an opportunity. We just re-procured our managed care contracts in October, so we're kind of in flux, shall we say. So we have not gotten to the contract where we would be implementing our value-based payment approaches, but I do see that as probably the biggest opportunity in the MCO contracts to really advance a care model or different ways of paying for care models that can incorporate midwifery-led models of care.
We do see that there's a tremendous opportunity there for state Medicaid agencies to leverage their power within a state in order to drive better reimbursement and improve access to birthing centers, et cetera, certified nurse midwives. So thank you so much. And Dr. Telecki, the next one is for you. You're up. Can you tell us a little bit about CHCF's future endeavors, and if any of them are going to be directed towards certified nurse midwives and in gaining increased access to birthing centers?
Yeah, so our current areas of focus right now are on maternal mental health and Black birth equity. And so, midwifery touches both of those, I think, especially the potential for impact in the Black birth equity space, but also just a general model really is supportive of maternal mental health. So I foresee us, we have funded things in the past related to clinical CNMs in the hospital space, because we have our maternity work has largely been in the hospital space, where 98% of the births happen in California. Increasingly, as we get deeper into the Black birth equity space, I think we're going to find ourselves in other venues, as I think at birth centers and other places, and that will lead us likely into work with other types of midwives besides CNM. So, slowly but surely, we are moving in that direction.
Mhm. Well, thank you very much. And it looks like we have about 5 minutes left. So I'll try to get one question for each of you in before we, turn it back over to Jennifer and Chloe. For Dr. Riley, what are your thoughts on alternative payment models for birthing centers, prospective payment models? Any thought or development in that area? I know that this is a big area of interest for a lot of our participants.
I'm all for it. So I think that there's, I don't know if there's a good approach that's been defined, but one of the approaches that I think could be particularly useful for this is through the managed care organizations. If there were ability to have subcapitated arrangements with birthing centers, with midwife-led models of care, I think that could be a great path forward. That's one that I, would love to explore here. It's just a challenge. I mean, you need to be able to license that provider type and that facility type, number one, and they need to be able to enroll as a Medicaid provider. But beyond that, there's I guess this is where the technical assistance comes in. You need provider types that can manage that type of payment approach. So I do think if I had sort of one wish or suggestion, I think if there were opportunity to explore subcapitated arrangements with these types of providers through the managed care organization, I think that would enable providing more flexibility to provide, not just to include the provider types, but also the types of services that would be needed that you aren't just sort of ticking off a billing sheet for.
Mm-hmm, mm-hmm. Absolutely. Flexibility is the key as we move forward, and being visionary as well. And we're so impressed with all of the good work that DC has done in this area. For Ms. Strauss, considering the importance of the policy lever in moving this task force forward, what are your recommendations or suggestions for those states who are looking to engage policy stakeholders?
I'm sorry, what's the question?
So what are your thoughts for other states?
Mm-hmm.
How can they put together coalitions or really drive policy that would improve access to birthing centers, and improve birth outcomes?
Mm-hmm. I mean, I think that it's really following the evidence. The evidence is so abundant in this area that the midwifery model and that birth centers achieve great outcomes. And I think that going back to the Strong Start study, that's really the first place to look, because we can look specifically at what the outcomes are in the Medicaid population and see that when prenatal and postpartum care is provided in a birth center, whether the person gives birth in a birth center or in a hospital, those same good outcomes are seen across any birth setting. So it's really about the prenatal and postpartum, as well as having that option during the intrapartum period. And I think it's really, turn to the evidence, bring in community members to talk about what's important to them. Talk to communities that are seeing the worst outcomes and the fewest options now about what those communities want to see for their options. And really, if you're looking at the evidence and what people, community members, pregnant people want, it's really a direct line to the midwifery model of care. And then it just becomes a matter of problem solving to figure out those tricky payment and licensure issues.
Mm-hmm. And and where they all intersect, and really how to engage policymakers. And Dr. Telecki, you also spoke to the issues of the importance of data and also bringing in all those who are interested, a big tent for stakeholders. What would be some of the top 3 takeaways for our participants today regarding your presentation and what they might do in order to advance policy and coalitions in their state?
Yeah, I mean, I think I emphasized that when I spoke, the importance of data and having good measures. And so I think even though, frankly, it's, people's eyes roll and fall asleep when you talk about measures and data, it is critically important to everything else that we're talking about here. The payment and all these other things rely on having good data. So, and good measures, and measures that everybody can trust. And so that is generally where I start when I'm trying to advance something as a funder, and is what I would recommend. And in California, we have funded the CMQCC, the organization that did a lot of the C-section work on the clinical side, to help get better measures about midwifery, the penetration of midwifery and things like that. So measures, definitely. You've got to figure out how to teach people to improve care. So there's something on the ground there that needs to be supported, both in the public and private sector. So there's, again, where you need the partnership. And in California, while we focus on the Medicaid population, the private sector is where a lot of innovation can happen. And in a state like California, we've got Google and, Facebook and all these places that have young people having babies who are demanding. And that is where, demanding in a good way. And that is where you sometimes can push, and then hopefully the public sector can come along and we can kind of use them to move each other. So that's another place that I would look. And then the consumer voice. We know that the Listening to Mothers survey that's been fielded nationally and also in California, we know that women know what they want. What they want is aligned with what we know works, and yet we continue to not do those things. That's doulas, that's midwives, that's integrated care, that's mental health linked into their visits with their OBs and pediatricians. Women, when you interview them, say that they know, they're clear, and yet the system doesn't listen. So there's got to be a way also to bring in those voices and try to get them heard in a way that will actually make change.
Thank you so much. Jennifer, I'll quickly turn it over to you.
Wow, that was a great way to wrap up that Q&A session. Thank you, Dr. Telecki, for those closing remarks, right on target. And want to thank everybody for their time today, for the thoughtful, informative answers and discussion that we had. As a reminder to our participants, no worries if we didn't get to all of your questions. We will be sending them to our presenters and giving them a chance to write written responses. We'll collate all of that into a Q&A document that will be sent to you as part of your post-session materials. And with that, I'm going to hand it over to Chloe to bring us home for today's session.
All right. At this time, everyone should have received an email with the link to complete today's brief 5-minute session evaluation. I also put a link to the session evaluation in the chat. If you did not receive that email, please contact me. My email is on the slide. We will be sending the presentation slides, session Q&A document, and archived recording of today's session by email to you within the next 2 weeks. Finally, our next session is scheduled on March 12th and will be focused on building the business case to support birth equity and spark policy momentum. Keep an eye out for a pre-session email with the agenda and required pre-session activities. If you haven't already, please remember to add Jennifer Moore to your email contact list to ensure that the series emails are not sent to your spam box. Her email is also listed on the slide. Thank you all for your participation today, and we look forward to seeing you at our March session.